Or unmuted.
Good morning, everyone. Welcome. This is Mobile and Grade Healthcare Advisory Committee. It is February 13th, and this is our pre-scheduled February 13th, 2026 meeting. I will call to order and ask Emily to do roll call vote.
She went by volume. There we go. Sorry, I need to get that taken care of so there wasn't an echo. Director King
Present.
and Dr. Hazel is out. Dr. Cornlow,
Present.
Samantha Mitchell,
Sorry, present.
okay, thank you. Joe Harding,
Present.
Amber Marr,
Present.
Shane Hardwick,
Present.
Andy Van Zee, Nate Metz.
He was online.
I thought I
Present.
seen him. And Jared Sykes.
Present.
Thank you. And good to have everyone either online or in person. We did well because I was worried about quorum for a minute, but we're only missing Dr. Yazel. We'll go ahead and start with the minutes and then I'll address in some open positions we have as well. So Emily had emailed out the minutes from December 12th, 2025. Any corrections or modifications to the minutes? Is there a motion to approve the minutes? So moved. Joe Harding with the motion. Is there a second?
Second.
Yeah, it was
Dr. Cornlow with the second then. Okay, let's go ahead and do a roll call on approval of minutes then.
Director King,
Approved.
Dr. Cornlow,
Approve.
Samantha Mitchell,
Approved.
Joe Harding,
Approved.
Amber Marr,
Approved.
Shane Hardwick,
Approved.
Andy Van Zee,
Approved.
Nate Metz,
You might have to unmute because I muted him.
Sorry.
Oh.
Approved.
Thank you.
Jared Sykes,
Approved.
minutes have passed.
Thank you. We will get those posted. Starting with the reports, Dr. Yazel is out of the country in Costa Rica. He offered to hop on, it was on vacation. I said I would not do so, if I were you. So I encouraged him to listen to himself, take some downtime. So hopefully he's having a good time there. I think, most of what we had to cover would be similar stuff. Procedurally, I have one that I want to make a, announcement and encourage that people consider recommending people for vacancies. We currently have 4 vacancies. 2 of them are beyond your control. One of them is the FSSA rep. We had Dr. Ty Sullivan. He has left and indicated they would reach out when there was someone else. So that position's vacant. Similarly, in the Indiana Department of Health, if you did not know, Dr. Crowder is leaving at the end of the month, or is it this month? I think it's this month.
Yeah.
And he's going to focus on family and kind of slow down some. And so Dr. Weaver is not available right now, but it will either be her or the new chief medical officer once Department of Health gets someone. The 2 positions we have open, we still have a need for an insurance industry representative. That's an open position. The second one is non-municipal MIH community paramedic program. And it was filled by Parkview, and they have offered to replace and supply Leanne in place. And I wanted to throw it out because I always hate to hold a spot for one organization and let them necessarily bump up until we see if there are other interested candidates. So Leanne is qualified. She has presented to us before. And I know Dr. Brown reached out and supported her. So she is an option for the non-municipal MIH community paramedic program. If someone wanted to move to approve her, we could consider it, or we can get the word out and see if there are other applicants. Okay, we will get the word out then and see, and hopefully at the next meeting, then we will address some of those vacancies. But thank you again for everyone being here, because otherwise quorum would have been a little tighter. Legislative updates, the bills that I am tracking, and I'm not sure that I saw any direct connection to MIH this year. So the ones that we are tracking are going to be House Bill 1003, which would merge the EMS Commission with the Fire Board of Professional Standards and Education and create a Fire and EMS Board of Standards and Education. It rolls off the tongue. I've been practicing saying it. So that is still pending bill. It has passed the House. It's in the Senate. And so we will have to see what happens with that. I believe it will change anything that currently addresses the EMS Commission, if it goes through, would address to that commission. And so, for instance, this committee then is in statute and it would revert to that. So I don't think anything would change for this committee, whatever the outcome of that bill. House Bill 1202 is various public safety matters, very lengthy bill. That's our agency bill. A lot of corrections and technical things. It does have a clause for EMS. We adopted rules for criminal background checks. We have loosely encouraged participation, but we have not enforced. And the challenge is that to run it through the state system, it has to go through the state police. And due to their arrangement with the FBI, they can only release results to authorized individuals. And when they submitted to the FBI, and the EMS Compact's well versed on that, and I'm the chair, so I knew it might be an issue. The FBI basically says the only way they will release to a state agency is if there is a statute, and they do not accept rulemaking as part of that. And so they were very clear. Justin Goodell, our current chief of staff, when he was general counsel, he and I drafted well, because of the way the commission's formed, they're actually acting on behalf of the legislature. So therefore, it is an enactment. And of course, we've had radio silence and they have not authorized us. So this bill would clarify in statute that individuals that want to be certified need to do a criminal background check. Does not impact people already certified. It's the new people coming in. And then it authorizes us to have access and use those results for vetting people. So that good news, no controversy there. That has proceeded. And it went through committee yesterday. And I'm trying to remember, it may have been recommitted. I need to look it up. So it may have another committee that will look at it. At House Bill 1251, Emergency Ambulance Services by Representative O'Brien, that is becoming known as a supporter of EMS and trying to reform EMS. And he has slowly been working on this issue of having county coverage. We've had a county survey a couple of years ago. This year, his bill would require that counties do an assessment and identify areas that are unserved by ambulance services. And then they are supposed to create a coverage for it, whether they assign a county coverage, whether they contract it or something of that nature. Was amended, and they do have an option that they can adopt an ordinance if they determine there's unserved, but they cannot afford to do so, then they can adopt an ordinance saying that they are incapable of doing that. So that kind of waters it down a little bit, but at least it has identification of areas that may be unserved in the counties. I, just being honest, I'm not sure it's a broad, and it depends on how you define it, but like a county. And I'm gonna use the example that I'm familiar with, because I talked to them at length, South Bend. They cover 2 townships as well. So, I mean, do you argue they are unserved because they don't have their own provider and it takes longer for South Bend to get there? To me, that may be a question of whether they're underserved, although I think they get quality service from South Bend. So you can see the county could figure out either way. I could see them saying, okay, that township's unserved. I could also see them saying, no, South Bend Fire is covering them, therefore they are served. So, and I feel like when we looked at the township level, there were very few that were just kind of hot, open, they weren't sure who was coming. And they would just put out a distress call and see, and no one was obligated. So that's what this bill would address. It did pass hearing yesterday. It's in the Senate now, and it was sent over to their finance committee due to the fact that it potentially could cost the municipalities. If they need to do that, they are capable of doing that. So we'll have to see what happens there. Those were the big ones that I have tracked for this year. I'll pause for a minute. Andy, I know you track legislative. Is there anything else that you can think of that you were watching?
No, I think it's pretty light year overall, in some of the healthcare side of things.
I agree.
The 1002, the representation was a little lopsided. Have they fixed that?
The 1003.
Or 1003?
The talk I have heard, and it has not been called to a hearing, I have heard that the EMS Association was pushing to balance it so that it wasn't quite as fire heavy and have equal fire. They have not called it. I know there are a number of commissions that are reaching out to Representative Bartels, so I'm not sure if that will be addressed in amendment. I heard they were looking closely at it, but I haven't heard anything to what they intend to do, so.
It could also go to conference committee, even if they pass it. So it could get changed behind the scenes.
What? That's weird that they would do that.
I call that the dark room phase, because Andy's absolutely right. So let's say they say, we don't think it's a good merger, and the Senate takes it out completely. Because the bill goes on, it's a different bill, so they would still have a conference committee, and that committee could decide to put it back in and choose their own composition. And then they just announce it, and then you have it. So it's a weird ending to the legislative session. For minor things, it works well, where they can push it out,
It's a
but
pretty major thing, though.
Yeah.
The lopsidedness of it.
Yeah, I mean, the bill will pass. I mean, I think that's it is a priority bill. It's a governor's bill. The bill itself will pass. The question is which commissions, which groups within it, and then some of the details is still being worked out. And then the question of, it all comes down to the original bill author deciding whether or not they consent with the changes or dissent. And that's when it goes to conference committee.
our agency works well with Representative Bartels because he chairs the committee we're under in the House. And so I do know the public position of IDHS is, and because we are under the governor, is we support 1003. And I would agree with Andy's assessment. I think the question is which boards and commissions stay in there. I have said that sometimes I feel like they imply that we agree with the EMS commission. And I just say I have concerns is what I say, but I have to trust the system to work it out. But there are people that are actively trying to get it changed. We are going to hear in a little bit, I will give more updates then. But we have some exciting news on EMS readiness. And then we also will go through GROW, which is the Rural Health Transformation Program. And in Indiana got a lot of money, if you aren't familiar, and we'll kind of go through what we're doing with that. But I think before we do that, then we are fortunate today. We do have presentation, and thank you to Amber Marr for connecting us. We have Anthem that is wanting to speak to us and update us on Indiana Pathways for Aging program that they have. And so I'm glad to welcome Dustin Ziegler, who I believe is online.
I'm here. Thank you. Appreciate it. Very much appreciate your time and the opportunity to share some information with you. As mentioned, I'm Dustin Ziegler. I'm the Director of Caregiver Advocacy and Programming for the Anthem Pathways program. Just real quick, if you're not familiar with Anthem Pathways, we serve everybody who is age 60 and over in Indiana who is on Medicaid. So we have about 44,000 members, and our main goal is to coordinate care so that these vulnerable folks can remain independent and in a setting of their choice and in optimal health for as long as possible. That's our bottom line goal with Pathways, is to improve outcomes and link to stay and independence in the community. I wanted to share some information today, and I appreciate Amber getting this started, because Amber and I connected a while ago around Anthem has a grant that is around, like, patient safety and other components. And we first started to engage around what would this potentially look like from a mobile integrated health program or model. And that's kind of the catalyst of how we got here today, is to see it kind of just sparked some interest around, as Anthem and with Anthem Pathways, and I will say Anthem Pathways, just FYI, it's very, very different than when you usually think of insurance or Anthem. We're way out in left field compared to what other people think. Like, we go into the homes, we coordinate care, and I feel like some of our objectives between Anthem and mobile integrated health run very parallel. So we wanted to introduce this grant and the potential for applying for it, but even beyond the grant, one of the reasons why I'm here is to just offer up some opportunities for further discussion around what would a potential collaboration between, Anthem Indiana and mobile integrated health agencies potentially look like, and what model would that entail. The why, I think, aligns really well from Anthem's standpoint. Our objectives that I think, as I understand mobile integrated health and paramedicine, and I know the research, we want to keep people out of the emergency room. We want to keep people from bouncing back, 36, 48 hours later, all these things. We also have challenges, particularly in rural communities, for us to be able to really maximize those outcomes within rural communities. So all that to say, I feel like there could be some alignment, and I need to learn more, and that's, I really look forward to your expertise about if this might be something to entail. But because I think our outcomes and our, just the benefits align so well together, we wanted to just have this, introduce this concept, this conversation, and see what might be able to come of it. My initial thoughts, if I was to, next step would be, having a conversation around maybe, and I'm just throwing this out here, but conversations around maybe like a pilot in rural areas, what that might look like. Because again, our objectives, I know based on the evidence how mobile integrated health would absolutely take the vulnerable people that we serve in these rural areas. It would be a lifeline, lifesaver for them. Some of these, as we know, some of these counties don't even have, a county hospital in them. And so when we have these very vulnerable, complex folks that we're caring for have these incidents, the likelihood of a bounce back or some other negative, clinical incident is very, very high. And so in recognition of what mobile integrated health does, I think that solves a lot of solutions for our objectives within the populations that we're trying to serve. And so we also want to know, what if we were to proceed, what does this look like for mobile integrated health? What potential benefits, both financially and other metrics and other objectives, how would this benefit mobile integrated health? Um, I think looking at some notes here, and just FYI, so I came to Anthem about 3 years ago. I was the first hire. I have been in nonprofit my entire career, so this is my first like corporate gig. And I only say that because I've worked with this population my entire career. Geriatrics, big focus on Alzheimer's and dementia, and we just know what this population encounters. And I just can't help but reinforce that, at least in my mind, from what I know right now, there could be some really, really innovative, cool collaborations here, if we want to consider diving into that. And like I mentioned again, beyond even just the grant that I mentioned, I think we're going to, I can't apply for the grant because it's an Anthem grant, but I did propose this model of care to be submitted as a grant for our patient safety initiative. But like I said, even beyond that, I think our next objective would just be, if there's interest from anybody in talking more and exploring more about what this might look like, I would love to sit down and gain your thoughts and see if we can be of benefit to you, and those that you serve, while also being a mutually benefit to us and the populations that we care for.
Thank you. Thank you. First of all, I appreciate that overview. I know that I will open up the floor for people to comment. I know Dr. Yazel and he wasn't able to get it scheduled before he left. We are looking to meet with him just to give kind of the broad framework of MIH and such and background. But I know Nate put some comments in as well. And so would anyone like to comment or give any feedback this time for Dustin on the pathways concept?
Hi, this is Samantha Mitchell with Crawfordsville MIH. We would love to talk more about this connection. Have had a chronic disease program for about 10 years now, and we've transitioned to a Pathways for Aging program. When that came out through the state, we saw the value in it. A lot of the patients that we work with need to go beyond those 90 days of enrollment with us. So we have piloted programs with United Healthcare before, and I think there's a lot of opportunity to connect with Anthem. So if we could get your contact, and I know I'm not the only one. I think there's several of us here that could benefit from that. So
Perfect.
if
Yeah.
we could get your information, that would be wonderful.
Yeah, I appreciate the enthusiasm. Yeah, I'll throw it in the chat, and I really appreciate that. I did forget to say, I might just a little bit of background history too. One of the reasons why I'm so into mobile integrated health, I mean, from what I know, because I only kind of know the surface, but just as a background, while we got so excited about this, I used to work at SACOA, which is the Area Agency on Aging in Central Indiana, and I was one of the founders of a program, and my friend Gene Ross, who's on this call, was instrumental in helping me, called Dementia Friends Indiana. I was working with Dr. Michael Kaufman at the time, and our first initiative, which was successful, was getting that Dementia Friends Indiana programming integrated into the state emergency, just for first responder training system. So that's when my interest first started, my understanding of mobile integrated health started, is my work with Dr. Kaufman. When I was at SACOA, what SACOA was doing runs very closely parallel to what we're doing here at Pathways. So the challenge was Dr. Kaufman ended up leaving for Eli Lilly. I almost immediately afterwards ended up leaving to come to Anthem. And so that idea kind of fizzled out until recently, talking with Amber and everybody. for this to come back up is a pipe dream, really, for me. And these are some of the conversations we had with Dr. Kaufman 6 years ago. And so to have it be revisited just has a lot of enthusiasm and energy on my part. So I appreciate the enthusiasm on your end, and I'd love to keep the conversations going and see what we can do.
Yeah, and I think since Dr. Kaufman's left, and he was definitely a torchbearer at the beginning. And I've been here since we've had this committee in 2020. And it's been a lot of, there were strong programs that were in existence when the committee formed, but looking at the growth and the prevalence, and I think we have a better assessment of that. And so I think we can probably help you, align what you're looking for as well. So, but I know the people on here, I mean, as I look around both online and in person, we have committee members, but we also always have a core group of the MIH providers. They're some of the more progressive, they want to make change, and they are looking for the means to do that. And so I think this is a good opportunity.
Absolutely. And the sustainability part is huge for us too. Like, what 10 years from now, how do we make this continuing to be a strong, effective, and financially stable model? Because it is very mutually beneficial. So I love it. Yeah, I appreciate the opportunity, and I absolutely love to talk more.
I have a question.
Yeah.
Hi, Dustin. My name is Alicia. I'm with Indianapolis EMS.
Hi, Alicia.
Integrated team. So glad you're here with us. Are you still seeing a minimum of 2-year wait period on that waiver?
And increasing. It's rough out there, Alicia. Yeah.
So I know there's a lot of discussion about rural healthcare and things like that. I too would be anxious to sit down and speak with you. We obviously in Marion County do a lot with SACOA. But on the pathways side, what it would look like on a high utilization urban community, because our elderly population is growing so quickly and, have a lot of 911 calls. So I would really like to look at that urban side of things with you if possible.
Absolutely. Yeah, I love it. And I mean, it'd be kind of cool to have, I mean, I don't want to dive into too much forward-looking things, but, to have, if we were even just to start with a pilot, to have a pilot in like kind of different geographic and different population settings, just to kind of get a feel for the differences. So absolutely, yeah. Be happy to talk.
Thank you.
Comments or thoughts? Okay, thank you, Dustin. We appreciate you being on and appreciate Anthem's, kind of being willing to move this forward. Chief, you can go ahead and make a comment or question if you'd like. Okay. But we appreciate Anthem's support. That's the one thing that has pleased me because we struggle on sustainability, as you noted, and to see that we've had several pilot programs, sustainable programs through insurance, rather than waiting on the state to lead that pace, which is taking a while. And so thank you. We do appreciate you guys being good partners in that way.
Absolutely. Thank you. I'm excited.
Yeah, that. Somebody's raising their hand again.
Amber, go ahead.
Yes, thank you. I just wanted to make sure that I let Dustin know that I did drop some of there was that opportunity in the chat that shows what website you can go to even look it up. But I know that there's a whole plethora of things that Dustin was talking about that folks can engage with him on, but just wanted to make sure that I flagged that that information is in the chat. So hopefully it can go into the minutes as well. And then folks can have that to look at for the future. Because I think the deadline, Dustin, for that specific opportunity is coming up. Is that correct?
Yeah,
For
and there's going to be
the patient safety price. Yeah.
Yeah, and there's actually I think you're already aware of it, Amber, but there's a webinar coming up too, I think towards the end of the month, that speaks a little bit more. But yeah, it's around the corner.
Awesome. And I did drop that link to the webinar in the chat for folks as well. Thank you, Director.
Thank you.
Thank you, Amber, for that connection as well. We appreciate your advocacy as well. New business, MIH program approval. We did not have any submissions, and so we are excited. Emily, have we had any in the back burner, anything coming down, or is it just kind of quiet right now?
So right now it's a little bit quiet just because it's kind of that lull between seasons. And we haven't really gotten to get out and advocate for programs and stuff. The only coverage area that we don't have right now, all of those counties that don't have any MIH coverage are all under the rural health transformation. So all of them except for one are considered fully rural. So those are gonna be the ones that we really focus on moving forward.
Okay, thank you. MIH opportunities, so one of them we'll get to is to grow the rural health. But the first one we have is EMS readiness. As we have evaluated EMS readiness, we ran into some hiccups because it is challenging under the current procurement to do things. And one of the things Corey has been advancing is to try to create a statewide data platform that would connect with the systems you guys are using that allow us to have visibility of what is going on. Unfortunately, that has been delayed and we cannot implement that this fiscal year. And so we have money and we need to use that money because it reverts back to the General Assembly. And so we have till June 30th. And so with that, then we as a team made the decision, the best thing to do would be to open up another grant cycle. And with that grant cycle, it's kind of a short turnaround and we apologize, but it is funding that is available to you guys. And so with that, Emily, I don't know if you want to share more on the parameters and such.
So since the NOFA went out just a few days ago, I have had a lot of questions regarding those that were awarded the grant this past round just a few months ago, as well as other questions. But those, if you have received a grant in the past, yes, you are still eligible. It's the same restrictions as last time. So as long as you're an existing program, a good standing with the state and are already a vendor with the state is a big thing. So because that process takes anywhere from 3 weeks to 4 weeks, it can take a significantly long time. But as long as you have those things, it should be a fairly seamless process. Other than that, I don't really have too much.
So yeah, you gotta kind of come up with your plan, but I feel like you guys usually are on top of your needs, but get the application in.
Yes.
We'll review it quickly, but then you will have to be prepared to move quickly. And as always, those are reimbursable grants because the state doesn't pay in advance on anything. And so like if you, and I had a question, could you do a vehicle? Yes, you can do a vehicle. You just need to make sure you can do it by June 30th. So that way we can get you reimbursed. The other question that I had is, was the question of how many awards are we anticipating and how much money are we allocating? And I said, I do not know. Not trying to be mysterious. We have at least 500,000, but EMS readiness can be used. It clearly states for mobile integrated health. So for instance, we've done another program for AD grants for BLS non-transport. We did not use all the money we allocated for that. So I anticipate that maybe 300,000 or 400,000 from that may shift over to the MIH. So I think what I'm saying is in a way, I'm like, I don't want millions of dollars in grants, but I'm hopeful that we can do even more than what we've done on the other cycles. And so hopefully this is a way to help the MIH programs and help improve the whole system. So Emily we have the one pager and she does have the QR code there to the grant information. And so please feel free to do that. If you have questions, reach out to her, Corey, or myself. We'll be glad to answer them. But I think this is a good opportunity. Okay, the next thing we have is. Let me close my screen. We have the GROW initiative. And I'm going to give a little bit of background, then Corey's going to talk about what we specifically are doing. And so I think Emily's may be different.
Is that,
No, hang on, I have my screen up here.
I see Craig's.
Okay.
You're on there, I just don't have the right one on.
Okay. So it's kind of a broad overview. So there is a CMS, Centers for Medicare Services. They offered a $50 billion grant to the states over 5 years. They want to spend about $1 billion. States started in around late August, early September. They had to do a full application and it had to be one application. So like the hospital association couldn't apply. We couldn't apply. Everyone needed to do it together. So state had the advisory board representing EMS was Dr. Yazel. They put in the application for 200 million, which would divide it evenly among the 50 states. And then CMS was weighing, and some states that were in a better position got a little more, other states got a little less. So Indiana was fortunate to get 207 million instead of 200. And so that is for year one. I try to call it a program because with the grant, it implies, I feel like people feel like you get that money guaranteed. So it's mapped out what we requested over 5 years, but CMS has the right to review after each year and they can modify those. So if you are not performing, they could take money back. If you are performing and need more, another state, they might transfer money to them. And so it's important that we are successful early on, or we could reduce our revenue further downstream. There are, I should know, there are a number of initiatives. I want to say closing on 20. Do you remember how many, India? I think it's about 20.
Well, there's 11 statewide initiatives and the 12th being the regional grant initiative.
Okay.
Now, within each of those initiatives, there's, I'll say, multiple projects.
Yes.
And so, yes, it probably works up to 20 different kind of tracks across all the projects.
And I think Andy's absolutely right. I know like there's stuff in there, or I think childhood obesity that falls in one of them. So the ones I have up here are the ones that I'm taking a look where they directly intersect with EMS. And as Andy indicated, the first 11 are more specific statewide, and then initiative 12 I have down there. We don't have a direct role at IDHS in it. But I think it's important that you're aware if you are in a rural area and we can get you that map or I can bring it up. But if you're defined as a rural area, then what they are looking for is like the main federal grant. They want each region to ask for one bucket of money and then spend it underneath. So what's that saying is if we are EMS, if we're mobile integrated health, if you are in an area, unfortunately you guys are not, but if you are in an area that is rural, then you would want to be at the table as these are formed and also as they are considering their priorities. So that way it includes EMS. EMS is mentioned in the actual parameters of it. And so it's important to make sure that we have funding for that. I know that with the EMS compact, our executive director analyzed and he was looking, and there literally are 14 states that have no direct mention of EMS in their spending plans. And that's kind of concerning from a national level. We were one of them that did pretty well, but we are looking at, we may advocate and ask CMS to further say, could they ask the states to designate like 5% of their funding towards EMS projects. if we did that, then actually we would actually increase quite a bit over what we are getting from health to administer. But it does become, the challenge I see with it is some of it, like the Medical Operations Center, Coordination Center, the MOC. You may have heard of our MOC, the regional concept. The reason they dropped it to MOC is they're trying to create a central hub that, and I guess it doesn't have to be located centrally, but a statewide hub that would coordinate the state. The idea is it would help coordinate interfacility transfers, but also could play a role like other states have done behavioral health. So if you have a mental health case and you're like, this person really needs to go mental health, and sometimes you guys get called as MIH. If you're there and you're like, okay, it's not a medical issue, you know, it's not they're diabetic or anything, this is related to their mental health, then they could create protocols then for people to determine that they can bypass an emergency department. And then the MOC would coordinate to get them admitted somewhere, so that way you can do a direct transport. So it takes a lot of coordination, hence it's a coordination center. But it is a promising project. Dr. Yazel, I normally would refer to him. It's kind of one of his pet projects. But if you have questions, you can speak to me about it. He is the one that is advising for EMS on the health side. We do not have, I don't have any breakdowns because we do not have any direct funding. We are just advisory in nature to that project. And then that project then, and we did submit a list. There's going to be year one is kind of forming the plan, and then also are going to have a stakeholder advisory group or a steering committee that would be kind of guiding these. And it does have has a lot of hospital representation, and a lot of those hospitals do EMS, but there's also direct EMS representation on that steering committee as well. And so that, I think that's going to be a positive on Initiative 1. Initiative 3 is growing improved patient outcomes through enhanced interoperability. The bigger projects are more direct data projects, and it wants to get the health records from EMS incorporated into the iHi system, but also look at getting information back. And I feel like probably we've had discussions in here that could really help MIH do our job if we were able to see the patient's background and know if they've been transported recently. And currently there are a few, I think IEMS has a program, they can see some of that. But it'd be nice to have this statewide, and that is a goal, and that's being administered by Department of Health because of the fact of the medical record is usually rests with the hospitals, and so that's usually in their regulatory purview. We do have one branch in there. They did include mobile integrated health because of the fact that they felt that that is a data issue to make sure that we have those health records. And so with that, we actually have mobile integrated health is under Initiative 3. And Corey had done an excellent application, and IDHS directly was a sub-recipient, and we have plans for implementing MIH data improvements. And with that, I will turn over to Corey.
Yeah, so the plan right now is to bring on 6 additional staff, which would be contractors. 3 would be liaisons, so similar to the district managers that we have. 1 for the north, 1 for central, 1 for south, and then 2 managers, 1 for north, 1 for south, and a data manager. The idea is to have these MIH contractors out in the field connecting with the MIH programs and other resources and attending those meetings with the anthem and those kind of things to connect everyone. And then once we have the data platform, onboarding all the programs so that all of that information is coming in so that we can have it in all one area. So when we have those conversations with FSSA or federal partners, we have the data to give them at that time.
I think we anticipate probably more interaction, because I know Corey and Emily try to get out, but they have other duties they are doing that is kind of heavy. And I think that'll open an opportunity too, where you're gonna see the MIH part of our office out there. So hopefully that will help build that data system, but we can also get a better feel for what you guys are currently doing and how that implements into a state data system. But I think there's a lot of opportunity there. Initiative 4 then is pediatric and obstetric readiness in rural emergency departments. We were, I laugh on this one. This is where sometimes you're too nice. I sat on an advisory capacity in it, and they were asking me, they're like, oh, we should fund some EMS things. And I'm like, oh, yeah, I said they could benefit from this and that. And I got them a little bit of numbers. Well, when everything got approved, they're like, oh, you're running those things. And I'm like, oh, I didn't realize that. Thank you. I thought you were doing that.
Sounds about right.
So, yeah, I got voluntold kind of.
Exactly what it was.
But with this, though, I think it is important. Basically, on the hospital side, there's gonna be a pediatric readiness from emergency services for children. I thought maybe they would do the EMS side, but a lot of times they end up tapping my staff anyways to do it. And so their thought was to have us do a readiness, and we're gonna look at the national standards of emergency services for children and see are organizations actually meeting those? Where are the gaps, and are there spending needs? And in future years, there's funding then to fill those needs. So if we're missing, say, a particular type of equipment, we can do that. We can do training, and we're still developing it, but kind of a little bit of a teaser. And I do think there is room, I will say, for MIH, because I think particularly as we increase the maternity deserts, and I just saw this week, another one is closing. And whenever we lose another hospital maternity, that creates an area that is underserved. And I think MIH has a good opportunity in this. And so we are still gonna put together with Emergency Services for Children what Indiana's pediatric readiness looks like. And then we essentially would have a grant system. So we will do the evaluation, we'll formulate what we want to see, and then you can apply to fill your gaps. If there are certain things missing and you want to become pediatric ready, then you would do that. And it's our hope that people do that. Part of the reason we are doing that is the same reason we do the MIH grants. The challenge becomes if we do a procurement and then we hand something out, it is very difficult through the state process, and a lot of times it's not very timely. Whereas if we do a grant that goes out, then that allows you guys to do it through your own procurement process and your local needs. And a lot of times it's a better outcome. So I think there's a lot of positive room there. Dr. Yazel is compiling a list, for instance, of simulation opportunities that would allow you to focus on OB and peds. And so look for more information on all these as we continue. I anticipate we will have updates, but I wanted to make sure everyone knew what was going on, kind of what's going to happen in this first year. And at that point, then I am open to any questions on it, because I know it's an exciting opportunity. We're lucky that CMS is wanting to improve the rural areas and also is allocating the funding to do that. Questions? Okay, if you guys think of anything, please let us know. Again, I'll continue to update as we get more information, but that's kind of as you're planning, I think it helps to know, like the peds, if you're looking at your MIH. Yes.
Yeah, so I'll talk a little bit about Initiative 12.
Okay, thank you.
The regional grant. So the state, when they developed the regional grant or the actual overall application to CMS, they set aside 40% of the funding for basically the first 11 statewide initiatives, and then 60% to be reallocated through a regional grant process. And the state has defined those 8 regions throughout the state that are primarily rural, a little bit, I'll say partially rural counties on the map. And so the state has identified through the Indiana Rural Health Association in partnership with IHA and the Indiana Primary Healthcare Association to serve as technical assistance providers for the regions to develop kind of a coalition approach to develop a unified application for submission to the state requesting dollars. We actually will be hosting some calls. The state did some initial calls a few weeks ago. We'll be hosting some calls starting next week with each of the regions. Homeland Security provided us with a breakdown of all the EMS providers in the state, and we assigned those to the different regions. And you should have received, and whoever the point of contact is for the EMS organizations in the state should have received a contact or an email with the registration. I will say we have identified at least some emails that have either haven't been delivered or got caught up in kind of as spam. But if you have any questions, feel free to reach out to myself. Happy to get any EMS providers looped in to these regional calls and efforts and coalitions. The state did kind of identify kind of the 5 priority areas for the coalitions, one being hospitals, local health departments, behavioral health providers, FQHCs and health clinics, and EMS providers are the 5 primary focus areas for those coalitions. And so the state intends to release the application in March. And actually, before I stepped in here, actually had the draft application for that, with the idea that these coalitions would be submitting their plans by July, with a October 1st award date for starting to fund these projects. These projects will have to tie into the overall kind of state initiatives, as well as the kind of outcomes that are outlined in the original state application to CMS. So I'll be serving as the technical assistant lead for regions 1, 2, and 3. Ben Harvey from Indiana Primary Healthcare Association will be doing regions 4 and 6, and Garrett Veal from IRHA will be doing 5, 7, and 8.
I will say, and I think this funding opportunity has been good, but I think it's been great to see the cooperation to, Andy named off the key groups. And I feel like it is a team effort at the state level that came up with this great application. And so I definitely, people need to be engaged when they get to the regional concept, and then they can get a lot done.
And I'll tell you where I see MS fitting may not be initially with some of the prioritization of what some of the region's going to focus on. Where I do see MS really playing a big part is probably in some of the implementation and delivery. Like, how are we going to fix whatever that issue is that we're trying to address? I see the EMS providers and probably MIH being potentially a big component of addressing some of those outcomes that the regions are wanting to focus on.
Thank you. Yeah, I agree, because I think, like I mentioned, the maternity example, they have to do some of these areas, and we also see a decline of, as Dr. Yezel has commented, people going into that angle of medicine because of all the liability issues and everything else. And so I can see MIH, in certain areas may have a key role in prenatal care. So, and they have been. I know we have programs right now doing that. And so I think that will continue to grow. Sorry, I did not mean to make a pun. Any other questions or comments? Thank you, Andy, for helping.
So I would encourage you to go out to the state website for Grow. There's lots of information on all these initiatives, the regional grants process. There's, documents, presentations. I see Nate Metz asked as far as how to get, involved, reach out to myself. Happy to ensure that your organizations and groups are, on the list. We do have kind of a master document of all the kind of stakeholders that, email addresses and points of contact for each of the regions and the different subgroups within each of those regions. So happy to make sure that everyone gets connected that should be.
Just putting that website in the chat, so it is.
Corey did too.
Okay. So yeah, you can look up
Who's ahead of you?
Grow there and find out more about it, so. Okay, our next meeting will be on Friday, April 10th, and that'll be at 10 a.m. here at Nate. I will entertain a motion to adjourn. So moved. Motion.
Second.
Thanks, Doc.
We will show us as adjourned. Thank you, everyone. Appreciate your time today and everything you do.
Thank you. Bye-bye.